So, leprosy or Hansen's disease. So, this has been a disease that has been running through the society for many years. Uh, Actually, it may be dated back to many centuries back. So, it is a long history regarding leprosy. So, it's a fascinating history to read about. So I'll be just going through these areas of aspects of leprosy. First, I'll be so without commenting about or without talking about the history of leprosy, this discussion won't be complete. So I'll first go through quickly through the history of leprosy, how this mm, disease-causing bacterium was identified. Then to the introduction, how about the manifestations of leprosy and some of the microbiologic aspects of leprobacilli. Then I will be discussing in detail about the pathogenesis and immunopathology of leprosy. These are the two things that I want to focus on. Based on that, we will classify the leprosy. Then after that, we will see some case scenarios. Along with that, we will see the key clinical picture and microscopy, followed by a very few words on treatment. So coming to leprosy or Hansen's disease. So it is it is known as Hansen's disease because it was named after this man. This legend is Gerard Hammer Hansen. So the story of leprosy doesn't start from this man, this Hansen. It has been there many years even before Hansen has born or Hansen started seeing the patients. It was there even many years ago. So in the earlier years before Hansen coming into the picture, everyone believed that this was something a hereditary disease, or many others believed the miasmic theory origin, all those obsolete theories about leprosy. So what Hansen did was he just thought differently. So what he could see was what he did was he started studying about the leprosy. So he was living in Norway. So what he found was that so in Norway during that time, during when Hansen started to observe leprosy patients in Norway, they started to build uh, certain leprosy hospitals, so that all these cases started getting admitted to hospitals and started getting isolated from the society. So what this Hansen observed was that once this was established, once these hospitals were established and all the leprosy patients were started to get admitted to that hospital, following this uh, hospital establishment, what he could observe was that the actual number of cases started decreasing, actual incidence of new cases started declining. This made him think that probably something might have been transmitted from infected ones to the uninfected ones and causing this disease. That's why when these infected ones were getting isolated in the hospital, the no more or the newer cases are getting decreased. So he strongly believed his theory of this, that some or need not be something is causing this disease and it is getting transmitted from infected one to the uninfected person. So he started working on it. He started taking samples from the lesions and he was trying to find out any organism or anything that he could observe in the microscope. So eventually Hansen, along with Albert Neisser, could somehow demonstrate a rod-shaped organism in the sample collected from a nodular lesion of a boy. So, this all the internet resources and other articles say that this was the first time that a bacteria was demonstrated to cause a human disease. So that was a revolutionary discovery. Hansen had that vision, had that thought process to bring this organism causing leprosy into the limelight. So over these years, lots of interesting histories and lots of stories are there for regarding leprosy. So it was a serious problem to the society. So there was immense social stigma, and the disease itself caused lot of disfigurement and disabilities to the persons. So you can see this. So there was lot of disfigurement to the face. All his hands were getting disabled and disfigured. So it was a big problem to the society. So nobody wanted to get exposed to these people. So they were actually isolated from the society, and people started worrying so much about this leprosy that many countries started building these prison-like setup or institutions to isolate the leprosy patients. So these are some of these leprosy colonies, or also known as leper colonies, that have been established throughout the world to isolate these people. So at that time, the main reason to isolate these was they all thought that this is highly communicable disease, and even sharing some few minutes with that patient might we all the exposed person will get the disease. So they were so much worried about the communicability. So now we know that it is less, it is low, it is a bacterium having low communicability rate or low transmission. And nowadays we have very effective treatment with the introduction of the multi-drug therapy. Leprosy is now curable. So all these colonies are not now functioning. All these have been shut down. But during that earlier days, these leprosy patients suffered from so much discrimination, and many laws discriminating leprosy patients were existing during that time, such as leprosy was considered as a ground for divorce, stating that leprosy is an incurable disease, so that you can apply for divorce and it was valid. Similarly, leprosy patients were not allowed to participate in elections or any public programs and all. So such was the discrimination that they were virtually excluded from the society as such. So that's little about the history. I think you should, everyone please try to read more about the history of Hansen disease. It's a very interesting story. Coming to the introduction, so it is a thanks to Hansen that he could demonstrate that there is a rod-shaped organism that is causing this disease. So we now know that it is a slowly progressive infection which is caused by Mycobacterium leprae that predominantly affects the skin and peripheral nerves. So these are the two sides that the Mycobacterium leprae would like to survive on. So these are intracellular. So these are intracellular. So they once they reach the human body, they will go inside the cell. It's not extracellular. It is intracellular, and they are acid fast rod shaped bacterium. So acid fastness is a property shown by this Mycobacterium leprae and also Mycobacterium tuberculosis. So what we mean by acid fastness is that so these bacteria have thick mycolic cell wall, so that unlike many other bacteria, these are difficult to get stained. It is difficult for the dye to penetrate this mycolic acid wall, so that they are not easy to stain. So we use some heating technique in seal Nielsen to actually stain the bacteria. So once it gets stained by some extra aided method, once it gets stained, the stain will be retained. So it has poor absorption but high retention. So due to this high retention, so usually in other bacteria we can decolorize the stained bacteria by using acid. But here, due to its high retention, due to that peculiar mycolic acid cell wall, all the stain get retained in the bacteria, and subsequently if we applied acid, it is not going to get decolorized. So they will resist acid decolorization. That is why they are known as acid fast bacteria. So there is acid fastness. They are intracellular. Now they have. So I said earlier, everyone believed that these are highly communicable diseases, but now we know that it is a low. It is having low communicability, and the incubation period is quite large, quite long. That is one thing. Another peculiar thing about leprosy: the incubation period is very long. It can start from months to many years, and then on an average, it can be 5 years. But there are incidents of up to 20 years. So that's why it remains as an endemic in several developing tropical nations. And now, in the current situation, India holds a major share. Around half of the global leprosy burden is bared by India. So also it is in the internet and other articles says that India is considered as the origin of this leprosy disease. So still India have a whole lot of cases. Annually per year we have around 1,20,000 fresh cases being reported. That is almost 58% of the global. Now, though leprosy is decreasing, it is still a major health issue in our society. Well, then another thing that we have to keep in mind is that not all people are susceptible to infection. So most of the people are not susceptible to getting infected. 95% are not susceptible actually. Then another important thing is that there are three main signs that we look for to think in the line of leprosy. They are skin lesions, thickened or enlarged peripheral nerves, and skin anesthesia or hypoesthesia. These are the three main signs that we usually look for. Now coming to the pathogenesis. So this I already told you that this has been with us for centuries, but till now the route of transmission and source of infection is not 100% clear, but to uh, a certain degree of accuracy we are now almost certain that the likely origin is respiratory secretion, and when the individual get infected by Mycobacterium leprae, the macrophages will take up Mycobacterium leprae. So they are intracellular, so they will go inside the macrophages and will go disseminate through the blood. And in the body, they will search for certain sites that are highly suitable for their survival and growth and replication. So for Mycobacterium leprae, the replication is the optimum temperature for replication is 32 to 34 degrees Celsius. That is, they love cooler tissues. So all our vital organs are core body temperature is much higher than this 34 degrees Celsius. It is 37. So that is why leprosy will go and look for areas where it is comparatively cooler in the body. So they will go and settle on skin and extremities, then organs like testes, in the nerves, etc. So unlike many other bacteria, Mycobacterium leprae doesn't secrete any toxins. So they don't have any toxins. All this disease manifestation is caused by the interaction between the mycobacterium and the host immune system. So virulence is based on the cell wall properties. So I said the nerve lesion and skin lesions are part and parcel of leprosy. So how does this nerve damage occur? So nerve damage can occur by the mycobacterium directly going and invading the nerve, and there is an inflammatory response that is getting mounted. That is the immune response that is getting mounted. So all those inflammation and inflammatory milieu will cause injury to the nerve and cause functional loss. So we now know that Mycobacterium leprae is having the ability to bind to Schwann cells. So they preferentially in the nerve they want to be inside the Schwann cells. which may lead to injury to the Schwann cells. So Schwann cells are concerned with myelination, so they will attack the Schwann cells. There will be demyelination and loss of function. So the mechanism of binding is now thought to be interaction between a laminin binding protein in the cell surface of Mycobacterium leprae, which will bind to the laminin protein in the nerves. So laminin protein is there in the nerves, and the Mycobacterium leprae has a binding protein which can attach to the laminin. So this is the schematic diagram showing. So they are intracellular organisms, so they go inside the macrophages, and when they attack the nerve due to the inflammatory mediators and inflammatory milieu set up near the nerves, it can cause injury to the nerve. So another thing that you have to keep in mind is that initially it is the small sensory and autonomic nerves that are getting damaged. That is why the earliest manifestations are in the form of this hair loss to the area, loss of ability to sweat, and numbness. So there is decreased ability to detect sensation like temperature and touch. So this is very important. So we have to assess the temperature and touch to pick up all these early stages. So in the early stages, it is predominantly the small sensory and autonomic nerves that are getting damaged. These are the small nerves and they get damaged first. Then later on, the larger peripheral nerve get damaged, resulting in more numbness, then motor weakness, or even paralysis. So that is how microorganism enters our body and attacks the nerves. Now, so that is how microorganism go and reach the nerve. Now we have to go know more in depth about the immunopathology of leprosy, because this is what determines the fate of the patient. So how the individual, how the host is going to respond to the invading Mycobacterium leprae. So the interaction between the host and the pathogen and the immunologic response mounted by the host determines which type. So leprosy, it is not a single entity, it is a clinical spectrum. So there is lot of lesions, different kinds of lesions depending upon how the patient respond to the bacteria. So some patients will respond very in a very efficient manner. So they will develop certain kind of leprosy and they will manifest in certain manner. But some other persons will respond very poorly to the bacteria. Such poorly responding patients will develop another entirely different type of leprosy. So based on this host pathogen immunologic response, there are different types of leprosy, or there are different spectrum of leprosy starting from good immune response to poor immune response. So we'll learn in detail about that. So here, to know the immunopathology, we have to know about cell mediated immunity. So I'll recommend to read about cell mediated immunity in the Robbins immunology chapter. So I'll just briefly brush up all those areas. So we have an antigen presenting cell. So once the Mycobacterium leprae attacks our body, our antigen presenting cells or the dendritic cells will process it and express it on the MHC class 2, and the antigen is getting presented to CD4 T cell. CD4 T cell and APC interaction will occur. Antigen presenting cell and CD4 T cell will interact with each other, and this will lead to release of lot of cytokines. So based on the predominant cytokine that is getting released, this CD4 T helper cell can differentiate along different pathway. So there are different subsets of T helper cell. One is T helper 1, other is T helper 2, another is T helper 17. So we will be focusing on T helper 1 and 2. So when the dendritic cells are releasing more interleukin 12, it will help the naive T cell or the naive CD4 positive T helper T cell to differentiate along Th1 pathway, so that in the presence of interleukin 12, these will differentiate into T helper 1 cell. So the major function of T helper 1 cell is to secrete interferon gamma. So the interferon gamma is a chemical mediator that will attract all the histiocytes or macrophages to the site. So suppose one tissue, so suppose the Mycobacterium leprae is going into the skin. In that area, this antigen presenting cell is presenting to the T cell, and the interleukin 12 is released in the dermis, and the T cells differentiate along T helper 1, and at that area interferon gamma is getting released. So as this interferon gamma get built up in that local area, all the histiocytes and macrophages will come into that area. So interferon gamma is an attractant, chemo attractant to macrophages. So all the macrophages will come and accumulate there, and they will get activated. So it is just not passive accumulation, they will also get activated, and they will become epithelioid histiocytes. And these epithelioid histiocytes are highly active, and they are capable of killing the intracellular microorganism. So that this collection of epithelioid histiocytes to counteract this microbe will form a granuloma. So the collection of epithelioid histiocytes is granuloma. So when there is a good Th1 response, ultimately it will result in a good granuloma formation. So granuloma formation is usually we classically associated with the tuberculosis. So just keep it there. That was the case of one individual. Now we will consider another individual who is not secreting that much interleukin 12. So during this interaction, his body respond in the manner that they are secreting interleukin 4. Instead of activating Th1 pathway, they are secreting interleukin 4. Interleukin 4 will help the CD4 or naive T cell to differentiate into T helper 2 subset pathway. So they will differentiate into T helper 2 cells. Now the T helper 2 cell will in turn secrete interleukin 4 and interleukin 5. So these are T helper cells. So the T helper 2 subset will help the B lymphocytes to secrete antibodies. That is the function of T helper 2. So they do this with the help of secreting interleukin 4, which will convert the B lymphocytes, which will help the B lymphocytes to transform into plasma cells, which are capable of producing immunoglobulin E. Similarly, interleukin 5 will attract eosinophils, and also they are also involved in secretion of immunoglobulins. So that is the basic thing. Now, so that was the two scenarios that we thought of. So in the first scenario, there was adequate Th1 response, so that there was enough interferon gamma getting released. So that individual will mount a very effective macrophage response against the bacteria, so that they will form granuloma, they will kill the bacteria, so that the bacterial burden or the microbial burden is very less in this individual. So such individuals are known as post-bacillary. So they will be having very less bacilli in the tissue that we can demonstrate, because they are getting killed by the effective immune response, the Th1 response. So due to the formation of granuloma, it resembles TB histologically. So they are known as tuberculoid. That is, oid means something is resembling there. So resembling the TB in histology with granulomas and all. So we can call them tuberculoid leprosy. So that is the individual having good Th1 response. Some other individuals, maybe due to many genetic factors and all, are not able to mount very good Th1 response against Mycobacterium leprae. So they are not efficient to mount a good Th1 response against Mycobacterium leprae. So this doesn't mean that their Th1 system is entirely dysfunctional. This only means that these individuals somehow cannot mount a good response against specifically against the Mycobacterium leprae antigen. So in that case, the Th1 response is poor, so that we know that cell-mediated immunity is poor. But there will be a relative increase in Th2 response. So when the one pathway is blocked or is less active, all the differentiation will be along the other pathway, that is the Th2 pathway. So but the disadvantage, so So there is no much cell immunity, there is not much Th1 pathway getting affected, so that they can't kill the bacteria effectively. So there will be macrophages in them. The macrophages are not getting attracted to the site, or they are not getting activated to form granuloma. Only then they can kill. So here there is no such interferon gamma secretion because Th1 is not happening. So that even though their macrophages are there always, but they are not getting activated, they are not getting collected around the microbe. So there is no granuloma formation, there is no killing of the bacteria, so that the bacterial burden is high in these individuals. So they are called as multibacillary because we can demonstrate lots of bacilli when we stain it with the acid fast stain. That is multibacillary. They are known as lepromatous leprosy patients. So in these patients, I said Th1 is weak, but there is relative increase in Th2 pathway, so that there will be antibody secretion. So Th2 is concerned with antibody production. So there will be still antibodies will be produced against lepra antigen. But we know that since the Mycobacterium leprae is intracellular, this antibody is not going to help anyway, because antibody is concerned with antibody can only attack the extracellularly circulating ones. So in the blood, suppose in the blood the antibodies are getting secreted, but when the antibodies will search for antigens, they cannot see any freely circulating antigens. Everything is inside the cell because it is an intracellular microbe. So antibodies is not going to attack them. So it is not even protective, but unfortunately they are secreting lot of antibodies, though not effective. So what happens is that due to this paradoxically increased antibody production, ultimately there will be formation of antigen antibody complexes in the circulation, and these complexes will get deposited at various places, which will lead to formation of erythema nodosum and vasculitis and glomerulonephritis. So erythema nodosum, it's a type of pancreatitis response, vasculitis and glomerulonephritis. Everything can occur because of the immune complex deposition. So you will learn more about immune complex deposition in your discussion on hypersensitivity reactions. Now coming to, so based on this idea, now you know that there are two ends. One is with good immunity, other is with bad immunity or poor immunity, having tuberculosis on the other hand, lepromatous on the other end. So based on this, we will now look into the various classifications. So Ridley-Joplin classification is the one of the most popular one. Now WHO has another set of classification. Then there is an Indian classification and a Madrid classification. So we will certainly look into the Ridley-Joplin, which is the most popular one. So it is based on the immune response or the immunity. So when there is strong cell-mediated immunity, there is good Th1 response, good macrophage activation, good granuloma formation. They are poor tuberculoid, pure tuberculoid. Then the other end of the spectrum is deficient cell mediated immunity. So their Th1 system is poor, and they are forming pure lepromatous type. And in between, individuals will develop borderline leprosy. So we have the one polar end is constituted by the tuberculoid type leprosy, that is having the best immune response, and the opposite end is that is having the worst immune response is constituted by lepromatous leprosy. And in between there are three borderline cases in Ridley-Joplin classification. These are borderline lepromatous, borderline and borderline tuberculoid cases. So this is the Ridley-Joplin classification. Now, so we know that tuberculosis type is going to respond very well, is going to kill all the microbes, so that it will be lacking any demonstrable bacilli, that is they are known as paucibacillary. We won't be able to often demonstrate bacilli in those individuals. And the other end is constituted by lepromatous, that is will be multibacillary, because these individuals are not having any efficient Th1 system, they are not forming activated macrophages, they are not forming granulomas. They will be studded with microbes and they are known as multibacillary. So this posibacillary and multibacillary is the classification that WHO uses. So WHO is posibacillary and multibacillary. So there are certain criteria for determining posibacillary and multibacillary clinically in WHO classification. So you will learn it in during your community medicine posting days. We don't have enough time to discuss all those aspects. So we'll limit it to Ridley Joplin. But you should know that there are other classifications like WHO classification, Madrid classification, and Indian classification. So now we'll go to case scenarios. So I have a 39-year-old woman who has a well-defined erythematous patch with the raised borders on the cheek. It is only seen on one side of the cheek. It is on the left side. It is an erythematous patch. The borders are slightly raised and there is loss of sensation. So now we have a case with a skin lesion and over that lesion she is having loss of sensation. So loss of sensation, so we'll think that there is something that is causing problem to her nerves, especially the sensory nerves. There is something that is affecting her sensory nerves and she has a skin lesion also. So I said there are three major signs in leprosy: skin lesion, anesthesia or hypoesthesia, and thickened nerves or thick and enlarged tender nerves. These are the three signs. So she on examination we couldn't find any enlarged or thickened nerves in her body, but we have two: skin lesion and loss of sensation. Now the next thing that you have to do is, so she has some problem with her sensory nerve. We have to know what is happening. So we'll take a skin biopsy from the lesion. So this is what we are seeing in a skin biopsy. So I'll just show a normal skin. So in a normal skin, there is a superficial epidermis. Beneath that, it is the dermis. You can see abundant dermal collagen and many adnexal structures, the hair follicles, all the hair follicles and eccrine ducts and all those adnexal structures are clearly visible in the dermis. This is a clean looking one and this is the section that was taken from this was the biopsy that was taken from our patient. So you can see that there is something abnormal in the skin. So it is not looking like normal. You are not seeing that, you cannot make out the adnexal section and there are some nodular aggregates of something in the dermis. There are multiple compact nodules that is in all throughout the dermis, that is in all throughout the dermis. So we are not seeing the adnexal structure. So we just assume in this scanner power, we just assume that maybe this might be collecting around this appendages and nerves, dermal nerves and appendages. We don't know. We will look into the higher powers, but there is something abnormal with this skin. So now we have a case with skin lesion and loss of sensation. So we are thinking in the direction of leprosy. So we have to know which type of leprosy this might be and how each type of leprosy will present clinically. So we'll look at the clinical picture whether it is getting matched with our patient. So as per the textbook description, tuberculosis leprosy will look like a flat red skin lesion. So it will be erythematous lesion. So our patient also had erythematous lesion. That's fine. Then the margins will be elevated and hyperpigmented. So here the margins are, here you can see clearly an elevated margin and the center is pale and depressed. So pale and depressed center and an elevated margin, an erythematous lesion. So our patient had an erythematous lesion with raised margin. The central pale area was not that clearly made out, but this is somewhat matching with tuberculosis. And the lesion distribution is asymmetrical. Usually in tuberculosis, you will get only in one side of the face or one side of the limb like that. It will not be symmetric in distribution. Our woman had only left sided cheek lesion. So another peculiar thing in tuberculoid leprosy is a dominant or predominant neuronal involvement. So in tuberculoid, the nerves get involved very early. Smaller nerves are getting affected first. They will get destroyed by the inflammation. This can lead to anesthesia. Finally, gradually, as the larger nerves are getting destroyed, they can cause contracture paralysis and auto amputation. When the facial nerve is affected, it can cause paralysis to the eyelids. There can be inflammation. So the eyelids get paralyzed, so that the lubrication, all the eye will get dried up, and it will result in keratitis and corneal ulceration and all. So in the right side, you can see a picture showing. Uh, so this patient has a tubercular leprosy. Her ulnar nerve was damaged and she has a claw hand. Then all the thenar and hypothenar muscles are getting wasted. So this can happen in tubercular leprosy, and neural involvement is a predominant feature or a dominant picture in tubercular leprosy. In tuberculoid, it's mainly skin and the nerves, and other organs are not involved in tuberculoid. So the microscopy what we see will be granulomatous inflammation that closely resembles tuberculosis. That is why it is known as tuberculoid leprosy. And the bacilli, so we know that the granulomatous inflammation, it is due to the activated epithelioid macrohistiocytes that will kill the bacilli. So you won't be seeing any bacilli. So they are known as posibacillary leprosy. That all you know. So now we will go back to our case. So in the you can see there is something that is infiltrating throughout the dermis, and it is a compact nodular infiltrates. You will go into the higher power. When we look in the higher power, in the center of this picture, you can see there is a nodular aggregative cells. These are inflammatory cells. In the center, you can see a giant cell. It is just the giant cell is just adjacent to the giant cell. You can see many cells. You can see some pink area. So the pink in HND staining is due to cytoplasm. So there is adequate pink color just adjacent to the that giant cell. So you know that these cells are having abundant cytoplasm due to the highly pink nature in that collection. Then immediately after that, the outside to that pink area, you can see a clear area or a pale area where you see the cells as small hyperchromatic or dark blue colored dots. You are not seeing any cytoplasmic pink color there. So all these are having very scant cytoplasm, and those are the lymphocytes. So we will go into the next higher power. So you can see a giant cell in the picture, which is having a peripherally arranged nuclei, which is known as the Langan giant cell. Then you can see some cells with abundant ill-defined cytoplasm and relatively paler looking nucleus. And in this nodular aggregate, you can also see many dark blue colored cell nucleus without much cytoplasm. These are the lymphocytes. So in again going into the granuloma, this is the granuloma. So here you can see, so you can see the pink color in abundance. So that is all these cells are having abundant cytoplasm, but you cannot see the cytoplasmic border. So these are having ill-defined cytoplasm. This is a collection of activated macrophages or epithelioid histiocytes. So the usually it will be the macrophages or histiocytes will be having somewhat round to ovoid nucleus, but here these are getting elongated, and some people will call it as slipper shaped nucleus. So all these are signs of activated macrophages and granuloma formation. This is a collection of epithelioid histiocytes forming granuloma. Again, if we look into another area, you can see that there is again on the towards the left, it is a large nodular aggregate of epithelioid histiocytes. It is surrounded by a lymphocyte cuff, and adjacent to this collection of epithelioid histiocytes, you can see some eccrine ducts and adnexal structures. So We now know that these infiltrates are near and around these adnexal structures. When we look at another area, you can see a nerve bundle. So the arrow pointed is a nerve bundle, and you can see the inflammatory cells surrounding the nerve bundle. So these granuloma formation, these lymphocyte infiltration, lymphocyte cupping, and all these are occurring around the appendages, around the nerves. So all these areas are preferentially getting attacked by the inflammation. So we know Mycobacterium leprae would like to go near the nerves. When they bind to the nerves, there will be inflammatory response. There will be granuloma formation. Everything occurs near the nerve. So that's happening here also. So we have large. So our case, we have large epithelioid histiocytes arranged in compact granulomas along the neurovascular. So this is not neuromuscular. I'm sorry. It is along the neurovascular bundles and surrounding the epithelioid histiocyte collection or the granuloma formation will be constituted by dense peripheral lymphocyte accumulation. So this will be a dense lymphocyte accumulation surrounding this epithelioid histiocytes forming compact granulomas. That is typically seen in this tuberculoid spectrum. Then the Nerman nerves may be obliterated or even surrounded by this dense lymphocyte curves. So you may not be able to visualize nerves because of the extensive inflammatory infiltration, and it will be obliterated. You may, if you do IHC in this case, you may see that in between these granulomas, you can see if we do IHC for nerve like S100, you can see that nerve fibers clearly uh, inside the granulomas and all. So nerve fibers cannot be easily visualized when there is extensive such inflammatory infiltrates, and due to this highly active efficient immune response, acid fast bacilli are rarely found. So they are, that is why they are called posibacillary. So again, in that case also we couldn't demonstrate any acid fast bacilli after doing weight fight, which we usually do. It's a type of acid fast staining, weight fight, that is usually done in our laboratory for demonstrating lepra bacilli. So the diagnosis was tuberculoid leprosy. Now we will move into another case. Oh, here this is a 40-year-old man. So he is having thickening of his forehead skin. There is loss of eyebrows and thickening of earlobes. So all his forehead skin, eyebrows is lost, forehead skin is thickened, and the earlobes are thickened. And as usual, so there is something abnormal. So loss of eyebrows is there, the forehead skin is getting thickened, so something is going wrong with that patient. Again, to get into a conclusion, you require skin biopsy, and a skin biopsy was taken, and this was what we could observe in his skin biopsy. So again, recollect the earlier picture of normal skin that I showed. It will be the you can easily see the dermal collagen rich dermis. Then you can appreciate the adnexal structures, hair follicles, and eccrine ducts. Then you will be so here you are not seeing anything else. That is, you are not seeing much of dermal collagen, you are not seeing any adnexal structures. There are something that is diffusely seen all throughout the dermis. Something is diffusely infiltrating the dermis. That is what we can appreciate at this power. Again, if we look carefully at the junction between the epidermis and the dermis, there is a clear zone. So there is a linear clear cut zone where between the dermis and epidermis, that is the dermal epidermis junction, there is a clear zone, and the epidermis is somewhat thinned out. So there is thinning of epidermis, subepidermal clear zone, and diffuse infiltration of some cells that we don't know, we will look into it, that is infiltrating throughout the dermis. In tuberculoid, we were seeing some compact nodules. Here, it is diffusely infiltrating. So, we now know that this lesion is anyway not tuberculoid, because we know the clinical presentation of tuberculoid. It will be erythematous lesion with raised margins and depressed pales, and there is nothing like that in this case. So this is not a presentation of tuberculoid one. So let's see whether it will match with that of lepromatous leprosy. So in lepromatous leprosy, when we look at the clinical features, so lepromatous leprosy is having these individuals, those who develop lepromatous leprosy, they are having poor Th1 response, they are having poor cell mediated immunity, so that there is high bacterial load. So they will involve lot of organs. In the tuberculoid, it was predominantly skin and the peripheral nerve. This will involve lot of areas. It involves the skin, peripheral nerves, upper airways, the nasal cavity, anterior eye chamber, testis, hands and feet. All sort of areas are getting affected by this lepromatous spectrum. Vital organs and CNS are not easy to attack because they are having higher core temperature, which are not suitable for lepra bacilli. So the lesion will be macular, mainly papular or nodular lesion, or the face, ear, wrist, elbows and knees. And with as the disease progresses, the lesion will coalesce to form characteristic leonine fascia. So these will be nodules and papules. These will enlarge. These will fuse, and then these will form deeply furrowed, deeply furrowed lumpy face with a prominent supraciliary arches, which is the characteristic leonine fascia. I will describe it once more when we see the image, clinical image. Then there will be mudrosis or loss of eyebrows. Then septal destruction or perforation can occur, and that may lead to saddle nose deformity. So this is the typical leonine fascia. So in our individual, he was having a lumpy face with or lumpy area with deeply furrowed skin. So deeply furrowed lumpy face. That is what that is described in leonine fascia, and along with that the supraciliary arch will be much more prominent. So this gives the appearance like that of a lion. That is why it is known as leonine fascia. Then when it attacks the upper airway or the nasal cavity, they will destroy the nasal septum, and there will be something that is known as saddle nose deformity that can be seen in the left bottom picture, that man having a septal destruction causing saddle nose deformity. Then the right bottom you can see a thickened nerve that is being demonstrated with the arrow. So in lepromatous case it will be symmetric. So the lesions will be symmetric. So here you can see in our case he had this deeply furrowed lumpy face in the left side and the right side. So it was symmetric. It was symmetric involvement. So initially the lepromatous leprosy, the initially it's much of a cutaneous lesion and the neural changes will occur later. In tuberculoid, then it was predominantly a neuronal involvement with skin lesion. Here it is a cutaneous lesion with neural change which occurs later only, and the lesions can be hyperesthetic or anesthetic, and the lesion distribution is carried. It will be more numerous in number. Tuberculoid will be one or two lesions, but lepromatous will be numerous lesions, and the distribution will be symmetric. That is the characteristic difference. In tuberculoid, it will be very few lesions and they are asymmetric. And there will be ulnar and peroneal nerves that are symmetrically invaded. So bilateral, you can palpate the ulnar nerves, you can palpate the peroneal nerves and many other peripheral nerves. And the nerve lesions are followed by trophic changes. So when the nerve gets damaged, or there will be trophic ulcer because of the loss of sensation. If it is in the foot, the person will not be aware of the getting hit or injured by any object, because he is not having any sensation, he is not having any sensation of that lesion. So that lesion is prone for developing trophic ulcers. And as I said, lepromatous leprosy is a disseminated one, or it can involve many organs. So when they involve the lymph nodes, they will contain aggregates of foamy macrophages in the paracortex, and the testis they will lead destruction of the seminiferous tubules and ultimately lead to sterility. Now in lepromatous leprosy, when we look into the microscopy, characteristically there will be a thinned out epidermis with a narrow clear subepidermal zone which is known as Gren zone. So our patient also had something like that. There was a clear subepidermal zone. So we now know that they are known as Gren zone and they are characteristically seen in lepromatous leprosy. Large aggregates of lipid-laden macrophages are seen. So these are macrophages. So macrophages filled with bacilli are usually seen. They are known as lepra cells or the Virchow cells. When we demonstrate it, when we look into the acid-fast staining, you can see masses of acid-fast bacilli inside these foamy macrophages. So they are known as globi. So these lesions have abundant or these are packed with bacterium. They are known as multibacillary leprosy in WHO classification. So now moving back to our case. So this was what we saw. So we now know there is a subepidermal clear zone in patients which favors lepromatous leprosy. But we have to look into other features. So here something is diffusely infiltrating the dermis. So we will look into the higher power. So in the higher power, if you look, you can see that these are all foamy macrophages. These are having, you can see enough pink color here. So these are pink to pale pink color. So these are having enough cytoplasm and this cytoplasm is foamy in appearance. So the dermis is entirely infiltrated by, diffusely infiltrated by foamy macrophages, and these are if they are containing these acid fast bacilli, then obviously we can call them as lepra cells or the Virchow cells. And the higher power, you can see that all these pale looking cytoplasm is filled with something, or you can, in this picture you will appreciate some granularity, but actually these pale looking cytoplasm, these macrophages with pale looking cytoplasm is actually filled with or is studded with leprosy bacilli. So if we do acid fast bacilli with modified Thiel-Nielsen staining, you can see the entire macrophage getting studded with the bacilli. So here also we have macrophages, but the difference is that these are not epithelioid, these are not activated macrophages. These are just passively admitting all the bacilli to build up and proliferate. These are not getting activated because there is no efficient Th1 response in these individuals, so that there is no interferon gamma for attraction and activation of macrophages. Activation doesn't happen, the granuloma formation doesn't occur, so they cannot kill the bacilli. So what the microbial burden will keep on increasing, and all that you can see is all these lepra cells or Virchow cells studded with masses of lepra bacilli. This is also known as globi, and this is the diagnosis in this is diagnosed as lepromatous leprosy. So these are the clinical and microscopic picture of the two polar forms or the two ends of the spectrum, one in the tuberculoid pole and the other in the lepromatous pole. Now then in between these two polar forms there will be some unstable ones or the borderline ones. So these polar forms are quite stable, they will remain like that, but the borderline ones are highly unstable. So to the ones which are having some amount of immune response comparable to that of tuberculoid is borderline tuberculoid, and at the other end there is borderline lepromatous, and in between there is borderline. So these are unstable forms. So what happens is that when there is no treatment and it is getting worsened, the disease is getting progress, these patients in the borderline tuberculoid spectrum will gradually move in towards the lepromatous pole. But with efficient treatment, we can convert or we can reverse the borderline tuberculoid patients or borderline patients to towards the tuberculoid spectrum, towards the tuberculoid type. That is, we are upgrading them to the tuberculoid form, to the better version. If it is not, if the treatment is not effective, they get downgraded to the lepromatous pole. That is the basic idea. That is why they are called unstable ones. So now as the bacilli is getting attacked, there will be a subclinical infection. Then there is an entity called indeterminate leprosy where the histological features and clinical features are not fitting into any of the Ridley-Joplin spectrum. It is indeterminate. So there will be some perineural and periappendigeal inflammatory infiltrates, and maybe you can demonstrate occasional bacilli also. It is difficult to diagnose. So we leave it that. You just realize that there is an indeterminate leprosy at the beginning. Then they will form the entire spectrum based on the different individuals' immune response capability. The individual can go either into lepromatous region or they can form tuberculoid leprosy like that. But when the natural progression without treatment is that the borderline and borderline lepromatous will these borderline cases will without treatment they will start to go towards the lepromatous pole. Then evolution with treatment, every all we have a effective regimen for the lepromatous and tuberculosis with multi-drug therapy, and they are curable. So the treatment is curable with multi-drug therapy, and the drugs used are dapsone, rifampicin, and clofazimine. Now that's about treatment. So we are coming to the end of our discussion. So I'll just introduce you to two other entities or two other terms. I won't be discussing in detail about that. So there are two reactions that will occur as the disease progresses during the treatment period. That is leprosy reactions. This can be type 1 reaction and type 2 reaction. So I said that in type 1 reaction what happens is that this borderline ones get moved towards one other. Suppose we'll just consider a patient having borderline tuberculosis leprosy. So we are giving treatment to that patient. So that patient is responding well and that patient's immune system is getting reconstituted. Suddenly when there is a good immune system response, there will be a immediate acute change to the lesions. That is what will happen in type 1 reaction. There will be an immediate acute change to the lesions. So suppose the patient is in borderline tuberculosis and is developing good immunity, he will get upgraded towards the tuberculosis type form. So that is type 1 upgrading reaction. From the borderline form, it is getting upgraded to tuberculosis form. Vice versa, if the patient is not getting response, the immune system is getting worsened, then this patient will get downgraded towards the lepromatous leprosy. In that case also there will be changes in the lesion. There will be new lesions. Like that in downgrading reaction there are specific clinical presentation. So I won't be going in detail about that. Again there is another type of reaction which is known as type 2 reaction or erythema nodosum leprosum. It occurs exclusively in lepromatous leprosy and rarely in borderline lepromatous. So it is exclusively considered to the lepromatous spectrum type 2 reaction. Now few words about lepromin test or Mitsuda test, which is nothing but a test very similar to the Mando test in tuberculosis. So here to know whether the patient is having leprosy, you will just take the lepromin antigen, inject into the um, individual, and we will look at the granulomatous response. That is the lepromin test. So to summarize, on the left, on the top left, you have a erythematous lesion with somewhat pale center. You cannot make out the raised margin here. So somewhat it is looking like a tuberculoid one. And in the histology, what you will see is nodular compact granulomas, which will be centered around the nerves, around the appendage and all. It won't form any diffuse sheet-like pattern. Whereas in the bottom picture, towards the left, there are nodules and papules and earlobe thickening, all you can see. And the histology, there is a thinned out epidermis, subepidermal gland zone, and diffuse sheets of macrophages, forming macrophages or the leprosils. So that's the end, and I would like to say that you all please read about Hansen. So this is a beautiful article published in 2019, I think, from Kerala. This was published by Reshma K. Kannu, who works in the Primary Health Center, Pathanamthitta, Kerala. This is a beautiful this article about the history of how Hansen made that revolutionary discovery and what all challenges he had to face, what all were the controversies during this. Everything is beautifully described in this. Go and read. Now, this in our district, in Thrissur district also, we have a leprosy hospital in Koratti. So what I want to show you with this picture is that there are still leprosy patients in these hospitals. It is not eradicated. Though the number is less, there are still patients living with all those disabilities. So they will require special care. They will require special footwear to prevent these trophic ulcers. They will need rehabilitation. So they will need much more care. And this is a good institution. But the what I want to highlight is that so they are not having a very good facility for this bathroom facilities and toilet facilities, which was reported in news 2 3 years back. And it was reported that many repair works are not being uh, able to be coordinated or conducted because most of the workers are not willing to come to this hospital, and because they are afraid of getting the disease. So I have visited this place. I have been through this with these patients once few years back. People even nowadays, even in this 21st century, the people have that stigma about leprosy. It is not completely gone. People still believe that if they go nearby this patient, they will acquire the disease. So that stigma is still persisting. So this needs proper health education, proper health education regarding leprosy. So with that, I think we have covered most of the aspects that I wanted to cover. Mainly was the immunopathology and pathogenesis. So I wanted you to get the concept regarding why certain peoples are going for lepromatous and why certain are having tuberculosis, and so that I wanted to clarify. I think I hope you all got a reasonable idea regarding that. Thank you.